Okay, I'll just rush through the valid points. So this 70-year-old male patient was referred from an Apex Institute, and he was a one-eyed patient. He was referred because he couldn't travel all that far, and he was staying close to my place. So he has actually lost one eye even after exanthematous fever in childhood. We don't know the details of what actually happened. He was having very good vision as per the patient in the seeing eye till recently. So he was diagnosed as having glaucoma, and he was on anti-glaucoma medications. All the previous records were not accessible for me, but I got few reports from the referring center, and further reports I awaited. In March 2019, he was having 618 best-corrected vision. In April, he was having 624. Then he went somewhere else from that institute and underwent cataract surgery. He came back to that institute in December 2019 with a vision of by 6. He also, in his history, says that the vision, after the cataract surgery, there was sudden decrease in the vision. Okay, so this was the clinical picture when he presented to me with a very angry-looking eye with a total limbal stencil deficiency. I can hardly make out the details in the AC other than the IOL shine. A small area of lid margin keratinization, but not as what we see in Stevens-Johnson syndrome. There were no significant symblepharon. So actually, from the Apex Institute, I received the letter that they were suspecting OCP, and I was requested to do the necessary further management and the investigation and management. Since I saw the clinical picture, I started a topical steroids, which did not show any clinical response. And in the meantime, I got the consent from them regarding conjunctival biopsy. The IF reported as having +1 fibrin linearly along the epithelial basement layer, and they called me up to say it could be a lichenoid etiology, something like lichen planus. So I got a dermatology consultation which showed no signs of lichen planus on the skin anywhere. And when I checked the reports, the isolated ocular lichen planus was reports are there, so it was suspected, and it was put as a working diagnosis. As per the reports, I started local immunosuppression. Initially, it was tacrolimus, but then unfortunately he couldn't get tacrolimus, and I shifted to cyclosporin later. So the clinical picture slightly improved. The vision improved to almost 5/60 to 6/60 best corrected vision. Now you can see the pupil and all those details slightly. And patient was having a subjective improvement, and the plan was to continue treatment. When he presented with a very severe, this was not the actual picture, this was after cleaning the discharge. He was having very purulent discharge and with an acute conjunctivitis-like picture. So the culture was taken from the discharge, and it was showed Streptococcus species. And as per the sensitivity, he was managed with the antibiotics. And to avoid a lot of medicines and the medicamentosa, I actually stopped for a while the anti-glaucoma medicines and also cyclosporin. But to my surprise, I saw that by the time his conjunctival infection got cleared, his cornea also got cleared, the angry-looking eye also got cleared, and now he's having a reasonably very good vision, not very good, but 660, he's reading one letter in 636 as well. So, should I revisit the diagnosis? Because I came across a report that there could be something called a brimonidine-induced lichen planus, and he was on brimonidine or combination medicine of brimonidine with timolol for a long time, even before his cataract surgery for glaucoma. So, anyone who has encountered such a case, or what is the opinion of panel, and what is the diagnosis?
This case report, you must have read this case report. Have they done the histopathological analysis also? So did they, or was it a clinical diagnosis what they have reported, the brimonidine?
No, very coincidentally, actually I got the full text only today. And just I brushed through that, and they are saying it is a biopsy report. As per the biopsy report, they have put it as a lichen planus.
Biopsy proven? No, okay, very
proven,
interesting.
Yes, IF, immunofluorescent.
Okay, that's very nice. I don't think I've not come across anything like this.
Yeah, that's very interesting, Sujit.
Yeah,
interesting case, interesting piece of information, because normally we do attribute drug-induced pseudopemphigoid. You can to anti-glaucoma medications. But a case of lichen planus related to use of anti-glaucoma medications is something that I have also not heard of.
Sujit, was there a causality established there, or was it a chance occurring? Because if you look at the number of brimonidine usage across the world and the incidence of one case report, I think you must report your case also, because these are the cases which actually gives a lot of credibility in the literature, where we see more than one cases and we know that, okay, certain can happen. But one off case when we see, then we think about chance occurrence, or is there a causality which is established?
Surely, I hope I can report this case. I'll first go through the report, the full text and detail, because as you told, there could be some factors that may be confusing also in this. But from the clinical presentation, how is it different from the pseudopemphigoid? Is that symblepharon, a lack of symblepharon, a characteristic feature in this?
If there was no subconjunctival fibrosis or a band of symblepharon that you actually notice, because sometimes to actually see that, you have to stretch the lower lid significantly and ask the patient to look up or the other way around to see for presence of any of these changes. And if you feel that there were none of those, usually in drug-induced pseudopemphigoid, you can see those mild changes, the subconjunctival fibrotic changes. So the difference between pseudopemphigoid and pemphigoid is that you don't have the autoimmune deposits in the basement membrane zone in pseudopemphigoid, unlike what you see in OCP. And with the withdrawal of the medication itself, the inflammations should subside. And when you do a biopsy, you don't really see the classical changes that you see in OCP. But again, you do have true OCP patients also, where sometimes the biopsy might be negative. So the usual way that we treat patients of pseudopemphigoid related to AGM is we try to shift over to systemic acetazolamide for a period of time to see whether that abates the inflammation in the surface. Use topical steroids if the glaucoma allows us to, just the soft steroids, and see if we are able to get the inflammation down. And if we are still not able to differentiate between the two and the patient requires an intraocular surgery, we do go ahead with the procedure under systemic steroid cover at least, even if we feel that it is the AGM to be blamed.
Okay, now I'm confused, like whether I should restart cyclosporin or stop brimonidine.
See, the thing is that I think if you have an alternate to the AGM, you can try a different class of anti-glaucoma medications. Yeah. Otherwise,
go ahead, please. Sorry, go ahead.
So, and use lubricants and see if it comes back, then you know that probably it is related to the use of the medication, because that's the only way, like Himanshu said, if you have to prove cause and effect, you will know only if you use the medication and you have a recurrence of symptoms, you will probably know that it's related to the medication or not. But at this point in time, if you're suspecting the medication to be the factor, then probably stop that and see whether you have an alternate to it.
Yeah, now there are those preservative-free anti-glaucoma medications that are available in Indian market also. So I guess they surely can try, and that's what normally we advise them to do, that just to see the effect, like what we are getting, because stopping the anti-glaucoma medication may not be acceptable by the glaucoma consultants. And also staining pattern, like I wanted to know about the staining pattern when you had that acute congestion, what you showed. It would be interesting to show the staining pictures related to your case.
I have staining picture. I have stained it, but I don't remember to have any particular pattern, and I couldn't find it in my, recorded or documented this thing. No ulcer, no ulcer. No.
Yeah.
No raw areas were there. Yeah.
Very nice. Very nice. You must try it.
I hope so. Dr. Karp, any comments on it?
Oops, wrong one. So I think that I have seen one patient that is similar to that. And I guess the other thing, you can check with the lichen plainness is the plasminogen factors. Did you look at that too?
No, I haven't.
Other factors. I think it probably is medication induced, but there is the other, potential cause of a lichen plainness appearance. So I would say, as Dr. Geeta says, keep off the medication and see then how the patient does, because it certainly was a remarkable improvement, and then see if it comes back.
Okay, thank you.
If you look at the other benign lesions like actinic keratosis or pseudoepitheliomatous hyperplasia, I think the OCT features would be sort of overlapping with OSSM. Is there a clear distinct difference between the benign lesions versus a lesion with a malignant potential, because your management would differ significantly?
I would say most of the time the OCT can help you decide what it is. Uncommon lesions like PEH, pseudoepitheliomatous hyperplasia, you do not see an abrupt transition. So I think that the four things that you're going to look for are the thickening, the hyperreflectivity, and an abrupt transition. If you have some and not all, what I recommend, and the thickness, which we said over 120-ish. So when you do a scan on a lesion, it's first important to do it in multiple areas, because in one area it may be so thick that you get shadowing and can't even see. So sometimes it's best to do it in another area, and you need to have your technician scan in multiple areas. So sometimes then the image will be bad, and sometimes you will get one where you can see those features. And if you have a lesion that does not have all, say in PEH, is going to have thickened hyperreflective epithelium, but no abrupt transition, and you look up and down and you can't find it, then you can say, I'm not sure what this is by my optical biopsy. And then you're going to need to do a tissue biopsy to be able to get it. So there can be overlap with, I can't always get the diagnosis, but I would say the vast majority of the time, I can find the features that I need to be able to diagnose this correctly. And I've done many of these studies where I do the OCT and then I do the biopsy. So that's how I'm judging about whether it's right or wrong. But nothing is perfect. So if you see something and you have an OCT and there's some overlapping features, you just can't really figure out what it is, then that needs to be removed. Not something that's going to be treated medically because you're not sure what it is. That needs surgery.
She's asking, when searching for lymphoma, how far back can OCT scan go? Do you use a special technique?
Okay, thank you for that question too, because I did not talk about one limitation of the OCT is that it works best on the bulbar surface. I do have colleagues in Canada who are working on it for the skin and for the tarsal conjunctiva, but it does work best and you can see best with the bulbar lesion. So for lymphoma, I can image all the way down. Anywhere I can see with a slit lamp, I can get a nice image. So all of the bulbar surface, as far back as you can get the patient to look down, we can image nicely for lymphoma. If it's in the caruncle, difficult to get a nice clear image. On the tarsal conjunctiva, if there's a tumor there, also it's sometimes very difficult to really see what is clearly going on. So when I'm imaging a patient with lymphoma was the question, and if it goes way back, as long as I can get either a lid speculum or get the technician to hold the lid and the patient to look way down, anywhere on the bulbar surface, even if it's high, or low will image very nicely for lymphoma, but not if it's in the caruncular area. That's hard to see, or in the very lateral canthal tissue, it gets more difficult. So most of the time I can get nice images and get a diagnosis, but in certain areas, it's just not so clear. This is a good question. Thank you.
We have a question from Dr. Vijayalakshmi. Normally, how long do we get symptom-free period after treatment with warm compresses and mechanical massage?
Okay, so that depends on how it's done. So if you are using, say, LipiFlow kind of devices on some mechanical device with a thermal pulsation, where you do see the response very fast. In fact, within a day or two, patient would feel much comfortable. In fact, when I tried on myself, I was comfortable on the day of the treatment alone. But the thing is, the longevity of such kind of treatment is not very great. So even if patient feels comfortable with such thermal pulsation and massage, after some time you may have to repeat it. Now, talking about the warm compresses and lid massage with your finger lid massage, it depends on how comfortable the person is with the massaging. A lot of time they just rub their eyes and touch their skin rather than doing a proper nice massage. And for that particular reason, a lot of us do an office expression of mebum, where very simple forceps we use, and we express the mebum in the office. And especially those who have chronic symptom, we prefer that. But otherwise, normally it's very individual and depends upon how bad the MGT is.
Okay, Vinay, any other questions for Dr. Himanshu or any other speakers?
No, nice presentations. I mean, huge topics, but all of them really did justice to it.
I think first of all, I think I must congratulate you, because managing these patients are extremely difficult. The commitment level on your part is amazing. I'm really mesmerized. And ups and downs, and you have been all through with this patient, and I think you are the best person to take a decision, whatever decision you take. Regarding this biopsy, regarding this, the chopping off and doing a cryo, I would personally not do it because I'm not sure of the etiology. Same for, MMG. Maybe Dr. Namrata Sharma would like to comment on.
I also think nobody could have managed it better than Anil, because he's deeply into it. And pemphigus vulgaris cases we've also seen, but we've not seen such severe GPC with it. They tend to have conjunctivitis that is known, and the cases which have been referred also not come across such severe GPC. And it becomes difficult to treat these cases, especially these giant papillae. So mucous membrane graft, I think I will not go for, because of the fact that etiology is really not known. But I think Dr. Anil is struck quite, he's hit on that etiology. It seems to be by pemphigus vulgaris only, but it's kind of a combined picture where giant papillae are also there, and it doesn't fit into any other diagnosis.
So there are two things that regarding that supratarsal rituximab. So I'm not sure because I have no experience. The only thing is, whenever we want to give anything supratarsal, we want to give some depot preparation, which stays there for some time. Rituximab, I don't think that is a depot preparation, and maybe it's just like giving supratarsal dexamethasone injections. And another thing is, Anil, sometimes it's not that you can fix all the eyes. You can try level best, which you have already done. So, but sometimes, nature has its own course. I think the systemic immunosuppression, that part which you have highlighted and you are already doing, I think that is the only thing. Even I would feel that along with the internist, I just like to keep his immune system as low as possible. Please keep us updated about this case. Very interesting one.
Thank you.
No, I just wanted
Thank you
to
so
know.
much,
I wanted to know what is against intralesional. That can be tried. Intralesional rituximab.
Yes, that can be tried. The only issue is that it's not going to stay for long.
Yeah.
So it's not a depot profession.
Yeah.
It's just like instilling frequent, topical eye drops. So only if it's a depot is going to stay for a month or so, then only, if at all. Here, I can't even think about it because it's different thing altogether. We don't know, it's like an OCP or these kind of presentation and how it's behaving. More of systemic, I think. We need to address the systemic immunosuppression part, systemic inflammation part, than the local per se. Thank you. Thanks so much, Anil, for presenting this case.
Okay, thank you.
There's one question which is there, I think, was biopsy done for these papillae? For Dr.
Anil, is for you.
Yeah. The papillae, I have not done the biopsy.
I think anybody would be wary of even touching those papillae. So you don't want to, because it is just flare up. They're so angry looking papillae. With so much of inflammation. The eye is very inflamed. I think to do anything surgically for such eyes which have systemic involvement, it is very important that the eye is not hot, it's white. I mean, I remember that's what Dr. John Das used to say, that your end point of treating an inflammation is that it doesn't look like a hot eye, I mean, it becomes white. Then you know that your inflammation is gone. But if it is so angry looking, papillae, I mean, inflamed papillae with discharge, then it's a difficult call to take. Did you find any difference when you started topical tacrolimus?
Yeah, initially there was an effect, ma'am. Up to 3 months when I followed him up, he was having decrease. There was a significant decrease in the size of the papillae and the symptoms also had improved. But after that, I think it waned out. He's a good patient, pretty educated. So he's continuing the tacrolimus, but it's not helping him now.
So regarding one of the previous presentation, Dr. Sharma, I think I love that tuck-in scleroplasty. So these days, Urvish, what he does is a glaucoma surgeon for his AGVs. He just places that scleral patch graft and then just covers the conjunctiva. He doesn't suture it. So we had a lot of discussion and we found that, actually it doesn't need suturing and it merges so well. Same way, but
Sclera is a more stiffer tissue than cornea. So it is easier to tuck in. It is easier to make a tunnel also, as opposed to cornea, it is softer than sclera. And this I did it, and then at that time Dr. Vajpayee was there, and I asked him what will we call this technique. He said tuck-in scleroplasty. So he is so fond of tuck-in that
tuck-in, yes, absolutely.
So tuck-in level, so he said tuck-in scleroplasty. Because we didn't publish it, and I picked these things up and so we are going to publish it soon, but it was published that time only. But yes, it is a very tuckable tissue, unlike a corneal tissue, which is not that tuckable. You have to make an effort to tuck it in.
And for this, what I'm telling is regarding AGV tubes, so they don't even make tunnels. Just place the sclera just like that, and it merges so beautifully well. So I think just when I was seeing that, I was remembering that's really nice one.
So another thing I wanted to ask was with us, there's so many times when you're tempted to use corneal tissue for scleral perks or for scleral, artery thickness less, because you think that, corneal tissue, it's a lot easier to suture. You can suture it much easily as compared to the scleral tissue, where, they are more difficult to suture. So, have you had experience of using corneal patches for scleral melts?
Yes. I have used a couple of them, but I feel that sclera is better. So it's just more physiological. All this cornea also becomes, after some time, it gets blood vessel, becomes whitish. But you can see that, this is an area where you had placed a corneal tissue. But the sclera, it merges so well. I personally feel that sclera, it's not very difficult to get. You can always use, full thickness, half thickness. The only thing, what I found is, whenever we are doing a scleral patch graft, we have to ensure that there is a good conjunctival cover over it. If you don't have a conjunctival cover over it, it may melt away. Recently we had a patient of scleral infection after squint surgery, which is
we all saw for the first time. Although we could manage that and we had made a scleral graft, that also melted. But I think if you have a good conjunctival cover, it helps. That's what I feel.
There's one question which is some any reason found for hilar lymphadenopathy in chest X-ray.
The reason is
That is when you said hilar lymphadenopathy, I thought it's going to be tuberculosis. I mean, I just took it for granted because everything which you cannot correlate with anything is tuberculosis. That's what I thought. I think that's a good question, but
you can definitely Anil, rule that out. Maybe must have ruled
That
out.
was ruled out.
Since the patient is on
I think
must have ruled it out.
That was ruled out.
They have done imaging and they have done sputum culture and sputum AFB. And I think that this one, the test that they do, Gene Expert they do. No? Gene Expert also they do for tuberculosis. That also was done. That was negative.
I think Laila madam is asking about
Ma'am, you want to take this rhinosporidiosis case? The question. So there's a question that there's a question that rhinosporidiosis of conjunctiva with scleral ectasia awaiting scleral patch graft. So I was just wondering that why do you want to do a scleral patch graft at all? It's rhinosporidiosis of conjunctiva. We had an opportunity of seeing a lot of them in Chhattisgarh where I did my post-graduation, and at that time we used to just excise it. Never had an experience after that. But scleral ectasia, if it is nicely epithelialized and it's quite, Dr. Sharma, do you still want to do a scleral patch graft?
no, I don't know. But since scleral ectasia is there awaiting a scleral patch graft, so I think there must be some. But anyway, if you have to do a scleral patch graft, then you must do. But how would you prevent the recurrence? I think that Vikas you should be able to answer because
we have seen like most of them we had to excise it, nicely excision, and these they generally happen when the person goes inside in a pond, and from there they generally get rhinosporidiosis in the nose. We have seen it into the this puncta. We have seen it into all over. So first, I think you should deal with rhinosporidiosis itself, and then think of scleral ectasia. These are difficult and challenging cases, and you have covered it so well, and highlighting the fact that we need to ensure that the disease is under control, be it immunosuppression before you take any surgical modality. Thank you so much. So if any other panelist has any other comment or any questions.
No, I think it was a beautiful surgical review. I just want to mention that these patients can have a systemic vasculitis that could be life-threatening. So you really want to get someone involved with rheumatology, make sure you're not missing a lung or kidney disease. I've had patients reluctant to get immunomodulation, and they just want to be on with steroids. And we actually had a patient that passed away really rapidly due to massive lung and kidney bleeding from Wegener's granulomatosis. So you have to be very vigilant.
So in cases in whom you need a tectonic support, like it will take some effect for the immunosuppressants to act. It will take about, for rituximab, if you want to give, it will take at least 6 weeks. If you want to give methotrexate or something similar, it will take about minimum 8 weeks to more than that. Yeah. So before that, do you suggest doing something like tectonic, like TBCL or something like that? Then after 3 months, you can do a second procedure, like a crescentic graft or something like that. Because quite often, if you do the crescentic grafts early, you see that persistent epithelial defects coming, melts happening, even if you immunosuppress maximum.
Yeah, so there are chances that recurrence would occur in these cases, even if you immunosuppress them. So if it is a small enough, crescent or a small enough PUK, I would go in for a glue. But if it is a large enough, which is probably full thickness with the iris collapsing out, I would still do it and then start the patient on systemic steroids in the post-operative period, as well as the immunosuppressive agents. So that in the initial 6 weeks, it is the systemic steroids which are taking care of the inflammation. And as we taper them, then the immunosuppressives are taking care of the immunosuppression. But yes, I completely agree with you, Anil, that if I can glue it, I would rather glue it, and keratoplasty would be the I would like to defer it for as long as possible.
Thank you so much, Vikas. Very beautiful talk and very nicely covered. And this reminds me of my fellowship days where you usually teach us like always remove epithelium before you could apply GA, and very minor points also will matter. And I have two questions from the audience. Eric wants to know, usually depending upon the basement membrane, orientation of the basement membrane, there will be onlay and inlay amniotic membrane. He wants to hear from you. Can you describe a bit more about that? And second part of that question is,
okay, so you said that which side of
inlay
the
and
amniotic membrane
onlay.
you should use, right? Okay, fine. So generally, what we
Yes,
do is
yes.
the area which is attached to the nitrocellulose paper, same way you keep the orientation, same side you place it on the cornea, right? In case you want to use this amniotic membrane as a bandage contact lens, then you can reverse it. But what I have found, and we have talked with many times with Dr. Sangwan, and I think Dr. Namta Sharma is also around. So it doesn't matter much, but it is always better to use the same side which is stuck on the nitrocellulose paper, same side you should, place it. Then, over it, the epithelium will grow. It will act as a basement membrane over which, epithelium will grow. In case you want the epithelium to grow under it, then in that scenario, you can reverse. I hope that answers that question, Anita.
That means the sticky side will be down. That means chorionic side will be over the cornea. And the second part of that question, while you are doing multi-layer AMG, will you use fresh fibrin glue layers?
Yes, of course. See, you'll take fresh fibrin glue only. It's just that sometimes you have 2-3 cases and you can, use it sequentially. What she's asking is, I think, can you use cyanoacrylate glue instead of fibrin glue for material? So no, that's not a good idea. So you will, for sticking the multi-layered AMG, you need to use fibrin glue only. Sometimes what happens is, if you have a small perforation here and there, even after that you have stuck the amniotic membrane, you may use cyanoacrylate glue over it, and we have done it in a few cases. But I think it's better to use fibrin glue for multi-layered AMG. And another question here is that what if it goes into NTHM? It's okay. It's fibrin only. It doesn't matter much. It doesn't cause any reaction. But I had in one case, I remember, where cyanoacrylate glue had gone into the AC. It was one of my very early cases, very small, and that got stuck on the anterior capsule. That caused a reaction. The patient had cataract, and while we were doing cataract, we had to remove that small piece of cyanoacrylate glue. Fibrin glue is totally physiological, and doesn't matter at all. If it's a traumatic perforation, can we follow the same perforation? No. Traumatic, if you have a corneal tear. So those are different ball game altogether and a different set of principles. If you have a very small perforation, maybe a lamellar one, very small one, maybe around 1 mm, 2 mm, then you can think of it. But corneal tear is a different ball game altogether, different principles, and I don't think that you should apply these principles over there. Dr. Namta, you want to comment on cyanoacrylate glue for multi-layered AMG?
I don't think with cyanoacrylate glue for AMG, I'm going to be very comfortable about it, because as you put the glue, AMG will tend to, come back with it. So I would rather suture it if I don't have a fibrin glue rather than put a cyanoacrylate glue. Sutures do well, and they, if you suture it with the protein on the conjunctival side, they do well. And amniotic membrane also works well and does its work.
Yeah, absolutely. So I think that question is clear on that. Gurma, you want to comment on anything? How you manage your perforation?
I think cyanoacrylate glue, like you said, is something that we all should feel very comfortable. It also has antimicrobial properties. So sometimes you have a small perforation from a fungal organism, you put the glue, and then the blood vessels come in, and then you heal. There's a publication from Dr. Dua about using fibrin glue in the anterior chamber. So you form the clot, and then you have the amniotic membrane on top, and that buys time to seal, and then the fibrin glue safely gets absorbed like a hyphema. So I've never tried that, but that's another publication.
So one of the surgeon I know, what he does is he does a YAG PI for perforations, and his principle, his thought process is this will ooze out some blood. Blood will come and make a fibrin and stuck it from inside, and ACs forms. I think the same principle. There's a question here that how many layers of glue do you use for multi-layered AMG? It is like if you're using a gum for sticking a paper, how many layers of gum you're using. It's not like that. It's a gel. So all you have to do is just place one drop and let it settle. In case you are using another layer over one layer, then you will have to reinstill the fibrin glue. Otherwise, for suppose you have already made 2 or 3 layers and then you want to stick, it's fine. But if on one layer you want to place another layer, then you'll have to use fibrin glue once again. After using a piece of amniotic membrane, how do you store it? No, you don't store the amniotic membrane. You use it and that's it. How do you use it? Restore it. If at all you want to store, that some occasion that in the beginning itself you have to cut it into 2 pieces. Suppose you have a 5x5 or 5x10 mm amniotic membrane, so you have to cut it, but for that you need to have medium also, and you place it either in 2 or 3 vials, whatever you want. But reusing fibrin glue is easier because whatever you want to reconstitute it, you reconstitute on the cornea. Otherwise, both the vials will remain in the incubator only, and we have used it even up till 7 days. You have to ensure that you sterilize the tip before you take your fibrin glue. And in winters, it doesn't stay well because in winters in northern India we have temperature goes even up to 2 degrees, 3 degrees. At that time, you can't store it for long.
No, I think our stem cell facility who makes this amniotic membrane has a issue. Once you take amniotic membrane with them and you thaw it, then if you've not used it for any reason, then they are not willing to take it back. So once, you have to be sure that you are using it and then you thaw it and then you use it. Because otherwise they say that they can't take it back. So I don't know about others whether it's the same thing, but that is the policy that they follow in our center.
Thanks, Gudmo. It was a wonderful presentation, and I think this quite exciting work that is happening in this field where we have some really bad infections. In the afternoon, I was in a webinar by Dr. Sarprezi where we saw that they're cross-linking as PAC CXL and all. So what I want to know is how does it work? So the mechanism of action is same as of cross-linking, what has been proposed. And second question is, in all cases where you have done rose bengal plus PDT, were these patients on antifungal or antimicrobial drugs as well?
Yeah, so both excellent questions. So I think it's very important to say that we don't feel comfortable yet treating because of the regulations here in the United States. I'm unable to do it as the first line of treatment without any treatment. So it's been hard to get a IND approval. We are working on it. So we have only been using it for as a last case scenario. So I'm a firm proponent, just like Hafesi, that we should use this technology early on, as soon as possible. When the infections are superficial, I think this is when it's going to show better results. And the mechanism of action is the generation of single oxygens in the microorganisms that are toxic for the microorganisms. One of the proposed mechanisms, for example, for acanthamoeba, even though we don't feel we can kill it as good in vitro as the fungus, we may be depleting all the other microorganisms that may be living in that cornea. Because remember the acanthamoeba, it needs the endosymbionts in order to survive. So we may be sterilizing the field, and the acanthamoeba is starving. So and those are proposed mechanisms.
Before we take a comment from Dr. Namta Sharma, what does it do to the normal stroma? So is there any, could you study that? Is there, does it make the cornea resistant? Means what I want to know is it that if you do it, then the drug penetration will be even less?
So we don't know about the penetration because all the tests that we've done is in rabbits that are not infected, they're not inflamed. So I feel that when the cornea is inflamed, the penetration of the rose bengal and the antibiotics or the antifungals should be better than when you have a healthy cornea. Now, it does the same, very similar changes that what you get with the riboflavin and the UV light cross-link. It makes the collagen fiber stronger. It makes it more resistant to enzymatic degradation. You do get, in some of these patients, a demarcation line. The problem with the rose bengal is it doesn't get absorbed as deep as the riboflavin. And that's why we're looking into different ways to try to deliver deeper. But again, we need to test the infected models. I think that it gets deeper as, the ulcer is larger. And some of these corneas, had severe melts, and they were 200 microns, 300 microns. And I think that was enough in order to at least arrest the melting process and give time for the medications that we have to treat the organism. But the acanthamoeba results are exciting. We were not expecting that. And we haven't had such a great results in fungal because we use it in very severe fungal ulcers. And the ones that we use it, I have many cases that I could share with you another day, but we've had some curvillarias, bilateral curvillarias, they're very anterior that respond beautiful, but the deep ones but the results have not been good.
Great. We have Dr. Namta Sharma with us, very dynamic cornea surgeon of India. We all know about it. And she has a very good work on all these infections. So, ma'am, what do you feel about non-pharmaceutical? So we are not using drug and all other treatment modalities that are coming up, be it PAC-CXL or be it Rose Bengal plus PDT. How do you feel about it?
I think PAC-CXL, it's going to come and it's going to be an adjuvant to the therapy that we use now, the medical therapy. There have been trials, and Dr. Hafezi was also trying to do when he was comparing, PAC-CXL versus no drugs. But I don't think that is going to have a future. I feel PAC-CXL will have to be combined, can best be can have an adjuvant role rather than substituting it with the medical therapy. For some of the cases it doesn't work. For instance, I think now we are clear that it doesn't work for fungal keratitis, but Dr. Mesco has shown such brilliant results with acanthamoeba keratitis, and although in the previous pictures using resident protocols by other investigators, we've seen very small ulcers being treated. But I was really delighted to see that his series has, big ulcers, as big as what we see in this part of the world, and severe ulcers, which we see here. So this is what, led us to believe that probably it will work for only small ulcers. And for small ulcers, maybe the antimicrobials would work, but it's really heartening to note, Mispa, your case series is just very good and very promising.
And you'd agree that we see many times a deeper infiltrate. So even if it's a 3 millimeter infiltrate, but if it's a deeper one, the prognosis becomes challenging. So for those deeper ones that we see here, so Gilmo, what do you feel about it? So can it go penetrate deep enough, or it's only the superficial one, which in any way can be treated with a routine antimicrobial agents?
Well, I think that we still need to follow the routine standard care with the antifungals. If we're talking specifically of fungal infections, the deeper ulcers, we have to find a way to deliver this medication. There are some publications recently that some substances that you can supplement to the Rose Bengal, like arginine and things like that, that will make it the absorption better. Maybe iontophoresis can be another way. What I propose here, and I think Dr. Hafezi is also doing, is that we need to do something, because what we have right now, we've been doing it for 30 years, and we need to come up with different ways to treat these infections, because the pharmaceutical companies are not coming with new antimicrobials. And Dr. Hafezi's idea is, he wants to have something that some areas of the world that have no access to antimicrobials, like some specific regions in Africa, for example, that you could have this lamp and you could do it for the early cases. And that's his dream, and this is what he's trying to do. But I agree with Dr. Sharma that the cases they present have very small ulcers, but that's the real world in many countries. So if you don't need to use an antibiotic and you can treat a very small ulcer with this, then that's great. It's a one-stop shopping. Maybe they need 2 sessions and that's it. You don't have to worry about resistance and toxicity, etc.
I have a question from Dr. Nirmal Jayadevan. He has complimented your videos, beautiful videos, and we have seen you using different techniques in poor ocular poor clarity, in corneal clarity, like using an endo illuminator with dealing with the pupil, dealing with the iris hooks, and going through a clearer cornea and all. And he has asked some tips to use, how to use the endo illuminator in hazy corneas. Some pearls for him. Okay,
well, maybe Dr. Sharma can also illuminate us, because she wrote that nice paper. But I use 2 different illuminators. So one is, depends on the room that I'm operating. If I have the access to the vitrectomy machine, I will use the endo illuminator from the vitrectomy machine, but most of the time I use the endoilluminator of an endocyclophotocoagulation. The endocyclophotocoagulation has an endoilluminator that can fit through a 1 millimeter paracentesis incision. And sometimes what I do is I turn off the microscope light, and you can just use the light of the endoilluminator, and you can sometimes use it as your second instrument. You can actually chop with the endoilluminator or assist you during your surgery. But when it's a difficult case, I recommend if you have an assistant, you can play with the endoilluminator, because sometimes depending on the scar of the cornea, etc., if it's very different that if there's scarring or edema, because the reflection of the lights will be different. And sometimes you have to put it inside the eye. Sometimes you have to shine it from the limbal area. And having an assistant that is knowledgeable in cataract surgery can also help, like a resident or a fellow, or even some of the nurses. Some of the nurses are very good. They've seen many cataract surgeries. So those are the pearls that I have.
Thank you so much. For the interest of time,